Welcome to the Cannabis Pharmacology Module, Section 3, Cannabis Dosage Forms. There are several forms of cannabis medications currently available by prescription. The first is dronabinol, which is synthetic THC available in capsules in the form of Marinol and an oral solution in the form of Syndrose. This is a C3 medication and is approved for AIDS wasting syndrome and chemotherapy-induced nausea and vomiting. Marinol is slow to work and takes about 1 to 2 hours for onset, and the dosing is very difficult to titrate. As with most oral cannabis dosage forms, the THC is metabolized extensively to 11-hydroxy-THC, so Marinol and Syndrose can cause excessive psychoactive activity, as there is no CBD formulated in the medication to mitigate the effects of THC in the brain. Sesamet, or nabilone, is a C2 medication which is a synthetic CB1 receptor agonist and is available in 1 mg capsules. It is approved for chemotherapy-induced nausea and vomiting, which is not effectively treated by other prescription medications. Epidiolex is the newest cannabis dosage form to be approved by the FDA in the United States. It is a C5 medication and is made from cannabis-derived cannabidiol, available as a 100 mg per milliliter oral solution. Epidiolex is approved for the treatment of seizures associated with Lennox-Gastaut or Dravet syndrome in pediatric patients. The makers of Epidiolex also have a medication called Sativex or nabiximols, which is not currently available in the United States. It is a cannabis-derived oromucosal spray in a 1-to-1 ratio of THC and CBD. It has been approved outside of the United States for spasticity associated with multiple sclerosis. Finally, the prescription drug rimonabant, which was a synthetic CB1 receptor blocker, was developed as a weight loss medication outside of the United States, but was quickly withdrawn from the market due to severe psychiatric side effects, which occurred after administration. Both dronabinol and nabilone have similar psychiatric side effects, but to a lesser extent than rimonabant. Both Epidiolex and Sativex have clinical studies associated with their use, and as they are plant-derived cannabinoids, have given us a significant amount of useful information when it comes to the dosing and indications for medical cannabis use in patient populations. A final note of interest is to look at the controlled substances classification of these medications. They are all classified as C2, 3, or 5 medications. However, the source plant which formulated the basis for these medications remains a controlled 1 substance, which is a direct contraindication to the classification of these medications. Unlike traditional pharmaceutical medications, cannabis is available in a large number of different dosage forms. The most common is the cannabis flower, which is typically sold as dried plant material in buds or ground. Cannabis oil can be produced by various different extraction methodologies and is typically sold in either vaporizer cartridges or for oral or topical use. Cannabis concentrates, which are known as wax, shatter, keef, hash, resin, or sometimes dabs, are concentrated forms of cannabis that have been extracted from the plant either by physical sifting and pressing or the use of solvents to separate the active cannabinoids from the plant waxes. As indicated by their name, concentrates are highly concentrated forms of cannabinoids and should be used with caution, especially with cannabis-naive patients. Cannabis tinctures are misleading by their name, as tinctures usually indicates the presence of alcohol. However, in the world of cannabis medication, a cannabis tincture can be oil-based, water-based, or alcohol-based, and are designed typically for sublingual administration. Cannabis capsules are similar to traditional pharmaceutical dosage forms and are familiar to most patients. However, As previously mentioned, their onset and duration of action differs significantly from the majority of pharmaceutical capsules patients are typically familiar with. Cannabis edibles are cannabinoids which have been infused into food or beverage, such as brownies, gummy bears, sodas, etc., and can cause significant confusion to the patient as far as how much to consume to achieve an appropriate dose. Cannabis edibles, similar to capsules, have a delayed onset of action, and patients should be counseled appropriately when using them. Cannabis topicals come in patches, gels, creams, and oils, and are meant to be applied to the skin. And finally, cannabis is available in rectal or vaginal suppository form for localized use or for patients who are unable to consume cannabis orally. Dosage forms vary widely in concentration, as well as in the ratio of different cannabinoids present. Concentrates and oils typically have the most concentrated cannabinoid content. The ratio of cannabinoids present within the dosage form is dependent upon the plant cultivars used and/or how different extractions are combined to formulate the final product. More information on the development of cannabis dosage forms can be found in our Cannabis Growth, Manufacturing, and Processing Learning module. Smoking cannabis has a very fast onset of action, within 5 to 10 minutes, and a short duration of action of about 2 to 4 hours. Smoking cannabis has a rapid onset, which makes it good for acute or as-needed symptom management. Dosing is also very easy to titrate based on the number of inhalations the patient consumes. And smoking cannabis is also the most affordable dosage form in most cannabis programs. However, smoking cannabis requires fine motor skills, as you must be able to manipulate the flower and put it into some sort of smokable cigarette or device in order to administer it. Accurate dosing can also be challenging due to variability in the depth and length of the patient's inhalation, as well as the variable temperature of the device being used. Smoking combustion creates toxic byproducts, including tar, ammonia, and polycyclic aromatic hydrocarbons, which can be harmful to patients. Chronic use of cannabis via smoking is associated with respiratory symptoms such as bronchitis, cough, or excess phlegm. Smoking cannabis also creates a significant odor, which can be unpleasant for patients or bystanders. Finally, 30 to 50% of cannabinoids are lost in the combustion process, which can be wasteful and lead to a decreased efficacy of medication. Despite this, smoking remains the most common form of cannabis administration and most closely mimics the endogenous activity of endocannabinoids, which are produced on demand and rapidly metabolized away. Cannabis vaporization has a similar onset and duration of action to cannabis smoking. There is, however, a significant reduction in toxic combustion byproducts and pulmonary symptoms with vaporization as compared with smoking. Additionally, little to no odor is created from cannabis vaporization as opposed to cannabis smoking. Vaporization typically requires some sort of power source and charging in order to keep a vaporization device active and able to function. Change in vaporizer temperature settings yield different cannabinoid and terpene vapor content, as the different cannabinoids and terpenes vaporize at different temperature settings. It is important to understand the difference of smoking versus vaporizing cannabis, which comes down to the difference between combustion and vaporization. Temperature is the main factor that determines the difference. Combustion is burning a plant at a temperature of greater than 451 degrees Fahrenheit. When cannabis is combusted, 20 to 30% of cannabinoids are lost due to pyrolysis, and 40 to 50% of the cannabinoids are lost in side stream smoke. Not only is this inefficient and wasteful, but combustion also produces toxic byproducts which are harmful for patients to inhale. Alternatively, vaporization occurs at a temperature of less than 451 degrees Fahrenheit. Vaporization is much more efficient and results in a significant decrease in a loss of cannabinoids due to side-stream smoke or pyrolysis. Vaporization also produces significantly less toxic byproducts, particularly when the product being vaporized is pure cannabis oil and does not contain any harmful excipients or thinning agents known to produce carcinogens when heated. Because different cannabinoids and terpenes vaporize at different temperature levels, vaporization also allows patients greater control over the overall effect of their medication. When cannabis is administered via the oromucosal route, onset typically occurs within 15 to 45 minutes, and the duration of action is 6 to 8 hours. The oromucosal dosage form has well-documented safety and efficacy due to the clinical trials of Sativex. It is also an easily administered and titratable dosage form. However, sublingual administration may result in an unpleasant taste to some patients, and alcohol formulations may irritate the mouth and mucous membranes. Sublingual administration also requires some level of dexterity to measure and administer the dose. Patients must also be carefully counseled on proper administration to avoid oral contamination of the dropper or syringe used to administer the medication. Other mucous membranes, such as the nose, vagina, or rectum, may also be utilized for mucosal administration for patients unable to use oral dosage forms. Many oromucosal formulations can also be used orally and/or topically, making them the most versatile dosage form. Patients should be counseled that if they swallow a significant amount of an oromucosal medication, the administration will be more similar to an oral route, and onset of action may be significantly delayed. When cannabis medications are administered orally, the onset is significantly delayed and takes about 1 to 2 hours to take effect. The duration of action is significantly extended, and most oral cannabis dosage forms last anywhere from 6 to 12 hours. Oral cannabis is convenient and discreet, and capsules in particular are a very familiar dosage form for patients. The long duration of action is also ideal for chronic symptom management. However, oral dosage forms can be difficult to titrate due to the delayed onset of action. Edibles, in particular, can be difficult to dose due to the lack of even distribution of cannabinoids throughout the dosage form. Oral cannabis also poses the greatest risk of adverse events if patients are not properly counseled on the delayed onset of action and administer several doses while waiting for the initial dose to kick in. Oral dosage forms are best absorbed in the presence of a fatty meal. Topical cannabis dosage forms remain a source of much inquiry among the medical community, as very little research is available as far as their onset of action, duration, and absorption. Topical cannabis dosage forms have been shown to be good for localized symptoms, and patches can provide long-term, discrete relief to patients. Typically, topicals have little to no systemic effect, which may or may not be of an advantage to the patient. The odor of topical cannabis can be unpleasant, and most formulations are oil-based and can leave a greasy feeling on the skin. Because the percentage of systemic absorption is unknown with topical dosage forms, it is potentially possible for patients to have a positive blood or urine test for cannabinoids after topical application, so patients should be counseled appropriately. When choosing a cannabis dosage form, the onset and duration of action is typically what is considered when choosing the appropriate form for patient needs. Often, a combination of dosage forms is what is best for the needs of the patient. For example, a patient with insomnia is looking for a long-lasting cannabis medication to avoid mid-sleep awakenings, but doesn't want to have to remember to take an oral preparation 1 to 2 hours before bedtime. For this patient, combining vaporization and oral dosing allows the patient both immediate and long-lasting symptom management. By the time the vaporization dose wears off, the oral dose will have kicked in, so the patient is not being dosed excessively. But we are utilizing both dosage forms to their advantage in order to maintain efficacy and provide the patient the symptom relief they need for their lifestyle. Another combination is to use oromucosal formulations as a maintenance dose with a vaporizer added as needed for breakthrough symptoms. Patients will also often use an oral mucosal formulation, hold it in their mouth for a minute or so, and then swallow it, so they get a combination of the short-term onset and long-term onset and duration with the same dosage form. Significant versatility exists when it comes to combining cannabis dosage forms, and your dispensary associates should be well versed in how to properly counsel patients as to the best dosage form for their needs. When patients initiate cannabis therapy, they should be encouraged to first find their effective dose through slow titration before assessing the duration of their chosen dosage form and increasing their frequency of dosing. As different dosage forms have different duration of action and a huge amount of patient variability, finding the effective dose first will allow patients to properly assess how long the dosage form lasts for them and how best to determine the frequency of dosing needed for their symptom management. Additionally, many cannabis dosage forms use medium-chain triglyceride oil, which is derived from coconut, as a base. So patients with a coconut allergy should use cannabis products with caution and always ask to see a certificate of analysis to determine exactly what is contained within the cannabis medication they choose. As mentioned in the pharmacokinetic section of this module, the absorption of different cannabis dosage forms has a wide variation, so when switching from one dosage form to another, different factors should be applied. When switching from an inhaled dose to an oral dose, a factor of 4 should be applied. And when switching from an inhaled dose to a sublingual dose, or a sublingual dose to an oral dose, a factor of 2 should be applied to estimate an equivalent dose. It is important to note that an equivalent oral dose may still produce greater psychoactive side effects than an inhaled or mucosal dose due to the greater conversion of delta-9 THC to 11-hydroxy-THC after first-pass metabolism. So further dosing adjustment may be required when switching patients to an oral dosage form from an inhaled or sublingual dosage form. Patients should always be instructed to keep their cannabis in the original packaging, both for optimal storage as well as for legal protection, as the label should contain their name, dose, administration, and practitioner of record if it is a medical patient. Cannabis should be stored in a cool, dry place, as light and heat can lead to oxidation and degradation of active ingredients. THC decomposes over time to CBN, which can result in a much more sedating effect and can be exacerbated by light and heat. Patients should understand that the potency of a product will naturally degrade over time, particularly when it comes to cannabis flower, so they should only purchase as much as they intend to use in a 2 or 3 week period to minimize the likelihood of loss of potency or growth of mold or fungus. Cannabis should always be kept out of the reach of children or animals in order to avoid accidental ingestion.